Title: Polymyositis and Dermatomyositis Explained, Step by Step. Hello everyone, this is Dr. Yogesh. Today we're diving into two fascinating autoimmune muscle diseases, polymyositis and dermatomyositis, together known as inflammatory myopathies. Let's understand them step by step in a clear and practical way. Both polymyositis and dermatomyositis are immune-mediated inflammatory disorders of muscle. They cause symmetric proximal muscle weakness, meaning patients struggle to climb stairs, lift objects, or comb their hair. The key difference is that dermatomyositis also affects the skin, producing characteristic rashes. Let's see how these diseases actually develop. In polymyositis, cytotoxic T cells invade the muscle directly, a cell-mediated process. In dermatomyositis, damage happens because antibodies and complement injure the small blood vessels that feed muscles and skin. That's why, under the microscope, we see perivesicular atrophy in dermatomyositis, a hallmark finding. Certain autoantibodies also appear in the blood. For example, antijo-1 and other antisynthetase antibodies are linked to a condition called antisynthetase syndrome, where, along with muscle inflammation, patients may also develop lung disease, arthritis, and rough mechanics hands. In adults, dermatomyositis can sometimes be perineoplastic, meaning it's triggered by an underlying cancer. So, when we see new dermatomyositis in an older patient, we must screen carefully for hidden malignancy. Now let's look at the typical features you'll find in clinic. Muscle weakness is gradual, bilateral, and mainly proximal. Patients often say, "Doctor, I can't climb stairs easily," or "I struggle to lift my arms." Their creatine kinase, or CK, is usually very high, sometimes 10 times normal, showing active muscle injury. In dermatomyositis, look for a heliotrope rash, a purplish discoloration around the eyelids. Also, Gottron's papules, reddish scaly bumps over the knuckles. There may be a shawl sign or V sign over sun-exposed areas. These rashes are often the first clue. Some patients have difficulty swallowing, breathing problems from respiratory muscle weakness, or interstitial lung disease. ILD can precede or accompany muscle weakness, so never ignore even mild breathlessness. Now let's go step by step through the investigations. First, blood tests. Check CK, aldolase, AST, ALT, and LDH. All indicate muscle damage. But sometimes CK can be normal in dermatomyositis, especially if muscle inflammation has burned out. Second, antibody testing. Order a myositis antibody panel, anti-Jo1, anti-2, anti-MDA5, anti-1 gamma, and others. These not only help confirm diagnosis, but also predict organ involvement and cancer risk. Third, electromyography or EMG. It shows a typical myopathic pattern and confirms that weakness is due to muscle, not nerve. Fourth, muscle MRI. It highlights muscle edema and helps select the right site for biopsy. Fifth, muscle biopsy, the gold standard. It shows inflammatory infiltrates in polymyositis or perivascular changes in dermatomyositis. And sixth, screen for interstitial lung disease and cancer. Do pulmonary function tests and HRCT if respiratory symptoms or antisynthetase antibodies are present. In dermatomyositis, perform age-appropriate malignancy screening, especially if the patient is anti-TEF1 gamma or anti-NXP2 positive. Let's understand the complications and why they matter. Respiratory failure can occur due to interstitial lung disease or respiratory muscle weakness. Aspiration pneumonia from dysphagia is very common but often missed. Cardiac involvement like myocarditis or arrhythmia can be subtle but dangerous. And cancer association, especially with dermatomyositis, must always be looked for. Regular follow-up, lung monitoring, and appropriate cancer screening are vital for these patients. Here's a real-world example. A 58-year-old woman presents with progressive proximal muscle weakness and a purple rash on her eyelids. Her CK is very high, and she tests positive for anti-TF1 gamma antibody. Because this antibody is strongly linked with cancer, we perform a detailed screening and discover an early ovarian tumor. After treating the tumor and giving immunotherapy, both her rash and muscle weakness improve significantly. The key takeaway is that antibody profiling isn't just a lab curiosity. It directly changes management and can save lives. Why do we spend so much time classifying these myopathies? Because different subtypes behave differently. Anti-synthetase antibodies make us think of lung involvement and ILD. Anti-MDA5 indicates a risk of rapidly progressive ILD. Anti-TIF1 gamma or NXP2 prompts aggressive cancer screening. Classification helps us decide how aggressive treatment should be, what organs to monitor, and how often to follow up. It also helps us counsel patients better about their prognosis. To summarize, polymyositis and dermatomyositis are autoimmune inflammatory muscle diseases. They cause proximal muscle weakness, sometimes with skin rash and lung or heart involvement. Diagnosis requires clinical suspicion, antibody testing, and often muscle biopsy. Treatment depends on the subtype and presence of complications like ILD or malignancy. And finally, here's a short practical checklist for clinicians from Dr. Yogesh. Always test for CK and myositis antibodies in unexplained proximal weakness. If antisynthetase or MDA5 positive, screen early for interstitial lung disease. In adult dermatomyositis, screen for hidden malignancy, especially if anti-TIF1 gamma positive. Use MRI or EMG to guide biopsy. And follow up regularly for respiratory, cardiac, and swallowing complications. Thank you for listening. If you found this helpful, share it with your colleagues and subscribe for more clinical deep dives.